called the PRECOMBAT study, extended follow-up of the PRECOMBAT study, 10-year outcomes after drug-eluting stents versus coronary artery bypass grafting for left main coronary artery disease, a very hot stuff. Now, Dr. Doo-Woo Park from Seoul, Korea, is the principal investigator and presented the study. And I don't think this needs much introduction, but maybe the introduction is because these were the first people who really addressed left main disease, and therefore it's worth mentioning what the results were at the beginning. As we know, there is a lot of debate about the Excel study, 5 years of follow-up, ECI equal to CABG, and so forth. So it's nice to see this paper here because it goes beyond that time, beyond 5 years. Basically, they had studies already published before that were studies on the first 5 years. And I like just to point out that the original study, the PRECOMBAT trial design, were patients with unprotected left main. There were 600 patients that actually they were 61 years of age, 76% male. And then the randomization exactly was about 300 with the cipher. This is very important. The cipher stent, which is not the most recent one type of procedure. I think this is very important to take into account. And the follow-up, they have follow-up at 1 month, 6 months, and then 5 years. I have to say that just to get a sense of these patients, the syntax score was 24. 9% actually have left main alone, 16% one vessel disease, 33% two vessel disease, 40% three vessel disease. And then in terms of the other lesions at the left main, they were comparable to be addressed with PCI and CABG. The patients had either ischemia, or ischemia products were about 5 times normal. So I think this is an important study that, in fact, the ischemia has been demonstrated with left main disease. This is actually the 2-year report and the 5-year report. I just want to say very simplistically, they look at an endpoint at the beginning, which was death from any cause, myocardial infarction, stroke, or ischemia-driven target vessel revascularization. And actually what happened is that in these aspects, it was a trend. I'm talking about the very early results. There was a trend in favor of CABG. And the trend actually was, in some cases, was significant in terms of non-inferiority. Okay, so what they decided to do is to carry on this particular study, and I just like to present to you the way that this has been done. This was initially planned, as I mentioned, for 5 years. I presented to you the short-term data with trends in favor of what I said of CABG. And then this extended into 10 years. How they did it is very interesting. The Korea has actually a universal health coverage system. It's all registered. So anything that you want to do is possible to grasp the data and to then get into studies like the one that I'm presenting today. So these individuals were followed for 10 years, and I just like to give now the report in terms of the primary endpoint. Okay, the primary endpoint at 10 years, PCI versus CABG, left main disease, was actually for CABG 24%, for PCI was actually 29%, a hazard ratio of 1.25. In terms of the composite, now they are excluding ischemia-driven revascularization and only use death, myocardial infarction, or a stroke. The results were exactly the same. Then when they use ischemic revascularization, of course, the CABG did better. When they look at death from any cause, there was no difference at all. So, in fact, if I now go into summarizing the results, this is what we can say. In a quote, PRECOMBAT was a first randomized controlled trial specifically targeting patients with unprotected left main disease. We did not detect any significant difference between PCI and eluting stents and CABG. The PCI with eluting stent and CABG is the first generation, I would say. And in the primary composite death, myocardial infarction, stroke, ischemia-driven revascularization at 10 years. The 10-year composite of death of myocardial infarction was also similar. Finally, the 10-year rate of ischemia-driven target vessel revascularization was a little bit higher for PCI than CABG, as it could be expected. So then we have to conclude that the 10-year follow-up of the PRECOMBAT trial of patients with left main disease and randomized to PCI or CABG did not demonstrate significant difference in the incidence of major adverse cardiac or cerebrovascular events. Because the study was underpowered, the results should be considered hypothesis generating, highlighting the need for further research. In fact, this is what we were saying. Was the number of patients in the study that was not high was 600 patients divided in two groups of 300, and this is actually the data as is being presented. The next, perhaps the final point that I would like to make is that there were some issues in terms of the follow-up, in terms of the data available and so forth. I don't want to go into much detail, but there was some detailed information that was not available and so forth. So I think that the study was as well done as possible, but remember, it's a first-generation stent. So I'd like to maybe ask you, David, what do you think? This left main is so hot, and here you have the longest term study you can have.
Yeah, I think it's interesting. I think it's a point for the left, a point for PCI, which I'm happy for. I think it's still I'm not sure that's going to win the game one way or the other, but I think it's interesting data. I'd like to read the whole manuscript.
Sure, Roxana.
Well, I mean, I think it's this, and as you know, Syntax, which was also a first-generation drug-eluting stent study, much larger in number, and they looked at the left main patients, which was a subgroup of the Syntax patients, and over a 10-year period, there was no difference in mortality. But let's not forget the Excel trial with 2,900 patients randomized to a next generation, best generation DES. We ended up with 1,900 patients who ended up randomizing between Xience, which is the best possible stent we could have, versus CABG. And there, the 5-year data for the primary endpoint of death, MI, and stroke was looked like it was exactly the same, but really it was 19.2% for CABG versus 22% for PCI, with the shifting of the mortality as well as the this hard endpoint of death, MI, and stroke in favor of CABG. And so I think when we bring this all together, it's always nice to see that the mortality looks the same, but I still believe we have to be very open to our patients that the early benefit of PCI, perhaps by having a similar effect to CABG, does not really translate to a durable result from CABG that gives you a really, really good enhanced outcome over time. So again, it brings us back to that conversation with our patients to make sure that they understand the early risks and benefits for both of these procedures, and have shared decision-making to make important decisions about the revascularization strategies.
I want to ask Kanu, frankly, by being involved actually as an editor of a journal, coming all these dilemmas and studies and so forth, I reached the conclusion that we are having perhaps more of an intellectual discussion than really practical. I'm just giving my opinion. And that is, to me, one or the other are good, and in patients who are not at a very high risk. And I think we are discussing a lot of detail, but I'm not entirely sure we will continue until we get tired of the discussion. I know, what is your taking?
Yeah, thank you, Dr. Fuster. Dr. Moran, I'm so glad that you brought up the really important concept of shared decision-making and personalizing medicine for our patients. I think more and more we're seeing patient-centered outcomes being the focus of how we treat our patients, but I think we need to see more about it. I think we need to see more about functional status, about quality of life, about patient preference, patient disposition following a procedure. Are they going home? Are they going to a nursing home or a skilled nursing facility? I think all of these factors come into play when we talk about what might be the right treatment decision for a patient. And I think I really still believe it's very, very much about individualizing the approach and talking to our patients and their families.
Very good point, I think
if I could just make one more comment, to both you and Roxanne, I really believe on staying on that line about personalization. I believe that in both left main disease as well as in TAVR, these decisions in the future are going to be made around your life expectancy and around your sort of long-term projection. Everything is safe. CABG is safe, PCI is safe, surgical AVR is safe, TAVR is safe. And I think that we're going to see a trend back toward, all these trials were done considering risk of patients, for instance, the structural trials. And I think we're going to land as heart teams on what's your projected 10-year survival. And I bet you in the long term, patients that need definitive care and to be cured and have long life expectancies will continue to be pushed towards surgery, and patients with shorter life expectancies or higher risk will end up having structural intervention.
Well, thank you very much for the discussion. I think we have to get into the next paper. The next paper is actually is about the radial artery versus saphenous vein for coronary artery bypass surgery. And also a long-term follow-up for Mario Gaudino from Cardiothoracic Surgery at the World Cornell Medicine in New York presented the study. And I'd just like to go ahead and give you, at least in a few sentences, what the study was about. Well, this actually evolved the so-called Radial study, which was a meta-analysis of 5 different groups that actually look at the possibility that radial artery could add some benefit to the use of only saphenous vein bypass grafting. And these 5 studies were pulled together now with a longer follow-up. Actually, the original follow-up was 2 years, I think it was 5 years, and now it's been stretched into 10 years. How can you follow patients for 10 years from 5 different studies? Well, this is a very, I have to congratulate how this was done. I have all the ways that were used, database, telephone calls, anyway, you make it, you name it. But the fact of the matter is that the study moved on, and the primary outcome actually was a composite of dead myocardial infarction and repeat revascularization in patients that have one of the arteries, radial artery, that was bypass and versus, or maybe the other arteries have saphenous vein bypass, and with another group that all were saphenous vein bypass grafting. The results of this particular study I just like to summarize, and that is the following. At 10 to 15 years of follow-up, the primary endpoint, death, myocardial infarction, and revascularization, you have when the radial artery is used is superior that only when saphenous vein graft is used without radial artery. And the p-value is very significant with a hazard ratio of 0.73. Then the whole thing goes into death and myocardial infarction. Death alone was also significant. It is all stratified into different groups. The final comment here is actually the summary of what is the conclusion of this undertaking, very difficult undertaking. In this individual, I quote, in this individual participant data meta-analysis with a median follow-up of 10 years among patients undergoing CABG, use of the radial artery compared with saphenous vein grafts was associated with a lower risk of a composite of cardiovascular outcomes and a better survival. This is the first report of survival benefit for CABG using multiple arterial conduits based on randomization data. Okay, David, what do you think?
I think very interesting, and I'm not sure. I think we didn't learn much more from the publication in New England Journal at 5 years in 2018. That was only 2 years ago, but the 5-year data was published 2 years ago, interestingly. And I think the conclusions are the same. Again, there are a lot of challenges, not only just with follow-up, but trying to combine these kinds of trials into anything meaningful. But I think that there is certainly a patient population that appears to benefit from radial. When you look at some of the incident curves, you see most of this is won by repeat revascularization in the first few months after surgery, it looks like on the curves, because they're fairly parallel, except for death later on. So again, I don't know what the criteria were for matching grafts and conduits and how all those decisions were made. And you always wonder about experience of surgeon in trials like this where you have so little information about how they got included. But I think there are some interesting signals here. The signal here is a little stronger for women than it was in the New England Journal paper. So, and I'm sorry, in the 5-year follow-up paper. So there's some interesting things going on here. I'm sure we'll continue to talk about the radial artery.
David, can I ask you, are we moving into arterial grafting? I mean, two mammaries and the radial artery, like some people in Australia have recently shown.
Yeah, I think that, this is an old topic, not a new one. It continues to get interest. And I think that the results are mixed, honestly. I think that this is another good discussion to talk about individualization, meaning I don't agree with all arterial revascularization in 80-year-old patients that have 4 and 5 year survival. Many groups do it because they want to tell us what their rate of all arterial revascularization is. On the other hand, I think younger patients, and particularly patients, if you know they don't have a normal saphenous vein graft, my gosh, of course they're going to do better with all arterial revascularization. So I think the answer is much stronger for a second arterial graft than for all arterial grafts.
Okay, thank you very much. I'd like to, just in the context of time, to move into the next paper. An interesting one is about e-cigarettes. This paper is actually the so-called E3 investigators in the trial. It is a randomized controlled trial evaluating the efficacy and safety of e-cigarettes for smoking cessation. This was presented by Dr. Mark Eisenberg and from McGill University. And it's an interesting study in a way that it tells you how difficult to stop smoking is. Well, I don't want to go into the issue or the controversy about the smoking. E-cigarettes may contain nicotine, may not contain nicotine. We can counsel people to discontinue smoking. We can do many things. And these are actually the basis of the study, was to examine the efficacy and safety of nicotine and non-nicotine, this type of e-cigarettes with individual counseling compared with counseling alone. Let me now be more specific. What we have here is 3 groups of people. All actually have been smokers. And in fact, one group out of, I have to tell you the number in a minute, I think are 70 in each group. I will tell you in a moment. But one group is nicotine, electronic cigarettes and counseling. The other group is non-nicotine electronic cigarettes and counseling. And the other group is counseling alone. This is actually how they were divided. And the study is really at this time is just focused on about 12 weeks, and is the report of abstinence of smoking, the reduction of the number of cigarettes, if there are side effects, etc. Something that we could discuss in vitro. Here's the number of patients. Okay, the nicotine e-cigarettes and counseling were 128. Non-nicotine and EC cigarettes were actually in counseling were 127, in counseling alone was 121. Average age 52 years, same number of women and men. The average cigarette smoking of this group was actually 21 cigarettes a day of the three groups. And what is interesting, 92% of these people who participated, they tried to quit the smoking before. So it's a very selective group that at least is trying again and again. I think this is important. Now, let me give you the results, and I don't want to disappoint you, but really are not too good. At 12 weeks, abstinence of smoking was actually 22% in the group with nicotine type of cigarettes and counseling, 17% in the group that were actually with non-nicotine cigarettes and counseling, and 9% in the counseling group. So actually the difference between the cigarettes with nicotine and counseling versus counseling alone was actually a difference of 12.8%. But you know, the maximal abstinence that was achieved was actually 22%. So the results were significant, but really a lot to be desired. Now there is a second issue, and maybe there is no complete abstinence, and then let's see what happens with the cigarettes that are being smoked. Well, an average of 8 on these people and the group that were actually treated with both counseling and there were nicotine cigarettes, 10% in the second group with non-nicotine in counseling, and 14 in the group that actually was only counseling. I'm talking about number of cigarettes. I think the issue of this paper, what this brings up, is that first of all, it's difficult to stop smoking. Obviously, this study apparently is going on, is continuing, but it's difficult to discontinue smoking. And certainly one can say that the use of nicotine cigarettes as a mechanism with counseling to discontinue smoking completely maybe is a possibility, but I don't know how successful this will be in a long term. In a short term, there is a lot to be desired. So I just presented in a very succinct manner what appears to be an interesting approach, but somewhat frustrating at the same time. Vivek?
Yeah, Dr. Fuster, I think it's really interesting. One thing to point out is that the trial was ended up being stopped early because of insufficient enrollment. So ultimately, they only enrolled about 3/4 of the number of the patients that they had anticipated, apparently because of availability of the e-cigarette, which is somewhat surprising. But in any event, it is disappointing.
Disappointing. Roxana?
No, it's obviously a very, very difficult study to do and underpowered for their endpoint, as well as their endpoint was self-reported, which is very, very difficult to obtain. We just don't know what's really going on. And so this could be an overestimation of the benefit rather than an underestimation of the benefit, because it is self-reported. And most people who are told, oh, we're going to stop smoking, they'll say, oh, no, I'm only smoking 2 cigarettes a day, when in fact they're actually smoking 18. So I think it's important to note all of those. But you have to give these investigators a lot of kudos for trying, but very difficult. I agree.
A lot of credit to the investigators, no question about it. Well, anyway, thank you very much. Let's move into the last paper. Very interesting. This is about who have ischemia and angina, and they have apparently normal coronary arteries, whether this is a spastic phenomena and the epicardial arteries or lack of dilation or reserve in the microvasculature. This is a very important issue, and we know that actually in a large proportion of women who present with angina or ischemia, this is what we are actually dealing with, and that is the possibility of the so-called non-obstructive coronary artery disease, or INOCA, ischemia with non-obstructive coronary artery disease. Well, having said that, I think this is an interesting study. I think it's full of surprises as the syndrome itself. let's say from the beginning that this was part of the ischemia study, and I don't have to go into the detail. These were patients with moderate or severe ischemia objectively found that were then had CT angiography. And just to make the long story short, for all these patients, there was a group that actually had non-obstructive coronary artery disease despite of ischemia. These were 21% of the total population. This is interesting. Age 63 years, women 66%, angina pectoris or atypical chest pain 71%, shortness of breath I think was 49%. And it's interesting, the degree of ischemia didn't correlate very well with the degree of angina. So these are patients which are identified as having ischemia, but the degree of ischemia and the amount of angina, they really did not correlate with each other. Well, having this is actually a descriptive study, a study that you follow for a year and you try to see what's happening. And the patients are medically treated. And the question is this syndrome goes away? Is it stays there? It gets worse? So let's see the results. Number one is interesting. I think this is fascinating. The amount of ischemia and or angina in the group with INOCA and the group with coronary artery disease at baseline was the same. I would have said that people with INOCA will be much less angina, much less this, much less that. Actually, it was exactly the same. And this is the first point to be made. This was actually at baseline. Then at about a year of follow-up, interesting, ischemic patients who had ischemic segments, they normalized in 50% of them. And in 45% of the INOCA patients, had changed or got worse. That's the next thing that it was found. The next question was angina was better in 39% of the patients. So 50% no ischemia, 39% actually better in terms of angina. What is interesting, also in the follow-up, there is no good correlation between the patient who has ischemia and the patient who has angina. So it's like you would like to have everything correlated and you are incapable to, but this is actually the data. So I think the problem of the study, frankly, is there was no invasive testing for microvascular disease was not done. Because the thinking today is these are patients who have spastic phenomena of the epicardial arteries and or lack of the power of dilation of coronary reserve of the microcirculation. And you address the first with acetylcholine to see if it causes spastic phenomena cardial arteries, and you address the microcirculation with adenosine to see that there is no increase in reserve. That's what should be done. This was not done in the study. So, and also the study excluded patients with unacceptable degree of angina. Well, and we don't know much about the medications being given. But this is the summary. NOCA patients are far more likely to be female, largely similar severity of ischemia on stress echo to coronary artery disease patients. This is fascinating to me. In half of INOCA patients, stress echo normalized at 1 year. 45% was the same or got worse. Angina frequency improved by clinically meaningful amount in 59% of INOCA patients at 1 year. No correlation between change in angina and change in ischemia. I think it's a fascinating study, frankly. Very difficult to carry it out. And is telling you how many unknowns we have in this particular situation. Roxana?
So an incredibly important study as a subset of Harmony Reynolds will present this, and it is really such an important study. Ischemia with non-obstructive coronary disease, mostly seen in women, is a really important. These women do not do well. They present, and a lot of times they're actually told they're crazy, but actually there is a lot. This opens, I think, the field, and this study shows us how much unknowns there are, and the surprises that you saw with the relationship of angina and ischemia, as well as their long-term outcome, is tremendously important for future research. And I think that these investigators have done a great job in actually looking at the patients who didn't get included in the ischemia trial, but yet they were studied in the CHAO study, which is this particular study. So very, very important for us to put a lot of importance of this study. Also, for the, in the Lancet Commission for Women, this is one of the big recommendations that we are putting out, that we absolutely must be paying a lot more attention to the microvasculature and understand the pathobiology of what's going on here, because they do not do well over time.
Thank you, Roxana.
Yeah, thank you so much, Dr. Fuster. I think this study was just, as you said, absolutely fascinating and also very humbling. I, again, want to underscore, of course, that 2/3 of the women were women, but also that half of these patients had a primary complaint of shortness of breath. And this is very much in overlap with the heart failure with preserved ejection fraction phenomenon that we're seeing, many of whom are women. It's touted, in fact, to be more prevalent in women. And we are beginning to understand, or at least we think we're beginning to understand, that there is microvascular dysfunction that underlies this phenomenon or this syndrome. And we're also understanding that oftentimes this is brought about by exercise. And so I think there is an overlap here between ANOCA and heart failure with preserved ejection fraction, particularly in women. I also think that this teaches us how complex the pathogenesis of angina is and how many variables go into it. It is the personal perception of pain. It is exercise induced and our reactions to exercise. It's our autonomic nervous system that comes into play. And so I think all of these things are really interesting. What I would be very excited to learn more about is the exercise capacity in these patients, specifically by doing cardiopulmonary exercise testing, which is a subject of investigation. But overall, really exciting, and commend the investigators for doing it.
The microvasculature, I agree, is completely important. Now, David Adams, you always like to look at the structures, and you look like St. Thomas. You cut what you see, and you move. And here you see a lot, and you cannot do anything.
I was hoping you weren't going to ask me something about that trial, VF. I think they summarized it very well.
Thank you. Vivek, you have the last word.
Well, no, I just thanks for having me. I think it's a very interesting series of trials, and yeah, I'm looking forward to hopefully doing this in person one day.
Well, thank you very much to the four of you. This was fantastic. I think it was a great discussion. It's an interesting group of papers, and I think intellectually I found these papers very, very appealing, and certainly the discussion that we have. Okay, thanks to all of you. We'll see you soon, and let's move forward and agree that we have to really overcome the problem that we all are facing worldwide. Thank you.